the introduction of the Hibatobuliary disease. طبعا اخذتوا انتم Hibatobuliary disease دكتور فائز المحاضرات، يعني انا هنا نبدي كمقدمه المفروض اعطيها هي بالبدايه، فاحنا صرنا بالاخير. We talk يعني about the anatomy, physiology, blood supply, and simple investigation that lead to differential diagnosis and diagnosis of Hibatobuliary disease. Firstly, we introduce what the liver. The liver is the largest and heaviest internal organ in the body, about 1.5 kg. Liver is the minister of the metabolism. It's involved with almost all the biochemical pathway that interest with the growth, fighting disease, supply nutrient, to provide energy and reproduction. So the liver is very important to our body to do all these metabolism. The liver cell called hepatocyte go thousands of the complex biochemical reaction every second in order to produce these function above. In brief, you cannot live without liver. So the liver is very important in our body because the ministry of most of the metabolism in the liver. The anatomy, simple anatomy, the liver is located behind the lower rib, right below diaphragm and the right side of the abdomen, separated superiorly by falciparum ligament, inferiorly by ligamentum teres. The right lobe is much larger. We have additional lobe, اللي هم quadrate and quadrate lobe. Histology, the basic unit and functional unit. The basic unit of the liver هي hepatic lobule, while the functional unit of the liver called acini. احنا نعرف functional unit هي the smallest part of the tissue that produce the same function of the organ. For example, the functional unit of the kidney, nephron. Functional unit of the lung, alveoli. So the functional unit of the liver called hepatic acini, which is anatomically almost the reverse of the hepatic lobule. The wall of the sinusoid consists of endothelial and macrophage. The macrophage in the liver called cover cell. The cover cell phagocyte the damage in function of the cover cell here, phagocyte the damage on aging RBC, engulfing bacteria, virus, and immune complex. So the scavenger in the liver is called the cover cell. This diagram shows the hepatic lobules and the acini. So the hepatic lobule consists from the central vein and the periphery hepatic trial. Hepatic trial يعني three hepatic اللي هو artery, portal vein, and bile duct called trial. Between the hepatic trial and the central vein, the liver acini located. This diagram shows the liver acinus between the hepatic trial and the central hepatic artery. The blood supply of the liver has a double blood supply. يعني two arteries supply the liver. Same as a lung, also double blood supply. Same of the retina, two blood supply. So the liver have two artery, hepatic artery, consists 1/3 of blood supply, bring oxygenated blood from the aorta. And portal vein, 2/3 of blood supply, bring the blood from the intestine and spleen. The nutrient, digestive material, all absorbed, pass through the portal vein. Venous drainage, the drainage is via the hepatic vein into the inferior vena cava. What's the liver function? the liver is the main industrial center of the body. مركز التصنيع in the body هو liver. The liver is very important in the metabolize protein, carbohydrate, fat, function making the bile, detoxification and fighting of, filtering of the blood. The liver has a great reverse power. What means that reverse power? It's usually only a small amount of its full potential so that can't lose about 1/3 of the cell until stop function. The potential power, the reverse power, that means even when destructed about 3/4 of the liver, but the function maintained. So this great reverse power means that the disease that affect the liver show no symptom in the early stage because this reverse power. This make the prognosis worse. That means the liver is diseased, but there is no symptom because the reverse power. The liver cell can regenerate themselves. الخصيصة الثانية اللي هي regenerative themselves of the cell. This regenerative ability allow the disease liver to return to the normal function in some cases. Very few organs in the body have this ability. بمعنى انه القدرة على regenerate of the cell to the normal. When there is acute hepatitis, after healing, lead to retain the same number of the cell after the healing of the disease. So the first line in the many patients with any liver disease are asymptomatic. This is a bad sign because the disease progress and lead to chronicity without symptom because it's reverse power. Maintain for years until the symptom appear. How to investigate the hepatobiliary disease? So the investigation of hepatobiliary disease, the investigation are very important. The first line and second line and third line to reach the differential diagnosis and final diagnosis of the biliary disease. There is a lot of biliary disease. How to reach the diagnosis? So we do a lot of investigation to reach the diagnosis. That means how to approach to the patient with hepatobiliary disease. Firstly, history examination and then investigation to reach the final diagnosis of the hepatobiliary disease. So our aim of investigation of patients with suspected liver disease, firstly, detect hepatic abnormality. We need test investigation to detect if there is abnormal liver or normal. Yes, there is investigation specific for this aim. Second aim, measurement the severity of liver damage. What are the severe, mild, moderate? Structural effect in the liver. There is investigation detect if there is change architecture, enlarged liver, nodular, that there is a specific investigation to do that. Identify the specific cause. The fifth, the investigation of possible complication. So what's the test that used to detect the abnormality? Are very important tests called liver function test. What do I mean liver function test? The liver function consists from measurement of serum bilirubin, either direct or indirect, or aminotransferase, the alanine transferase, aspartate transferase, alkaline phosphatase enzyme, gamma glutamine transferase enzyme, albumin, and prothrombin time. So the liver function test, firstly, bilirubin. Bilirubin, increased bilirubin in the blood called hyperbilirubinemia, result from the accumulation of bilirubin product from the heme metabolism, heme destruction. The source of the heme come from either from the damaged RBC or from hemoglobin or other source, myoglobin, liver enzyme. And so an increase in the bilirubin in the body tissue and maybe due to the abnormality in the either to abnormality of the liver or abnormality of formation of the RBC or abnormality of the transport of bilirubin to the through the liver, or metabolism abnormality in the liver, or due to abnormality in the excretion of bilirubin from the liver. So divided the bilirubinemia either hepatic due to destruction of the RBC and increased bilirubin, or due to hepatic cause due to parenchymal liver disease, or due to decreased excretion نسميها post hepatic due to poor excretion. When the hepatic hyperbilirubinemia mainly unconjugated hyperbilirubinemia increase, while when the hepatic lead to both conjugated and unconjugated increase parallelly, but when the both hepatic اللي هي obstructive jaundice mainly conjugated hyperbilirubinemia. The normal level of the bilirubin in the serum 0.2 to 1.2 milligram per deciliter. An increase more than that level called hyperbilirubinemia. The jaundice appear when the serum bilirubin more than 3 milligram per deciliter. Between the 1.2 to 3 milligram per deciliter and ecteric hyperbilirubinemia, there is increased bilirubin without jaundice. Unconjugated hyperbilirubinemia may be result from the overproduction of bilirubin, while the conjugated hyperbilirubinemia may result from the bilirubin from the liver. الليفر انزيم اللي هي كجزء من الليفر فانكشن تيست هي الامينو ترانسفيريز. The aminotransferase enzyme. These enzymes often referred to the transaminase are present in the hepatocyte and leak into the blood with liver cell damage. So when there is liver cell damage, lead to discharge of this enzyme to the serum and then detected by the test that indicate there is a liver cell damage. We have two enzymes. Aspartate aminotransferase is a primarily mitochondrial enzyme. 80% تقريبا in the cytosol. And it's also present, but it's non-specific because it's present in the other organ other than liver, in the heart, present in the muscle, in the kidney, and in the brain. So any disease of this organ lead to increase this enzyme, so non-specific. High level are seen in the hepatic necrosis, myocardial infarction, muscle disease, conjunctive heart failure, so non-specific. Alanine aminotransferase, other enzyme is cytosol enzyme, more specific to the liver, so it is raised only when occur in the liver. This is more specific than the aspartate transferase. Alkaline phosphatase enzyme is present in the canalicular and sinusoidal membrane of the liver. It's also present in other tissue, such bone, intestine, placenta. Alkaline phosphatase enzyme in the liver are located in the cell membrane of the hepatic sinusoid and the biliary caniculi. So any disease of the biliary caniculi and biliary system, like obstruction and inflammation of the biliary system, lead to elevated this enzyme. So this enzyme indicate if there is obstruction or obstructive jaundice or obstructive biliary disease. Accordingly, the level raised with intrahepatic and extrahepatic biliary obstruction and with sinusoidal obstruction or occur in the disease that infiltrative to the liver. So any disease lead to obstruction of the biliary system lead to elevated of this enzyme. هذا الانزيم يفيدنا في تحديد انه if there is biliary obstruction or not, increase in the obstructive jaundice. Other enzyme called gamma glutamyl transferase enzyme. This is a microsomal enzyme Mildly elevated of this enzyme is a common even with a small alcohol consumption and do not necessarily indicate the liver disease. So in the patient, consumed alcohol lead to an increase in enzyme, but it's not necessarily indicate there is a liver disease, but also an increase in the cholestasis in parallel with alkaline phosphatase. So when they increase this enzyme together with alkaline phosphatase, that indicated there is an obstructive disease. But when they elevated only alone, that indicate either alcoholic or due to either a drug lead to induction of the microsomal enzyme, any like tegretol, some antibiotic lead to induction of the microsomal enzyme and lead to elevation of this enzyme alone. This table show the differentiation between hepatic or biliary obstruction. So biliary obstruction, we see there is an increased alkaline phosphatase more together with gamma glutamate transferase, but mildly increased AST and ALT. In the hepatic disease, the AST, ALT increase more than alkaline phosphatase and GGT. But when there is alcohol or any enzyme inducer drug lead to only increase GGT, only increase gamma glutamate transferase. So from this table, can we differentiate it by this enzyme, differentiate between this, if there is liver disease or due to hepatitis or due to biliary obstruction. In the liver disease, we need to investigate the hematological abnormality. So hematological investigation, the routine hematological investigation are often abnormal in the patient with chronic liver disease, can give a clue to the underlying disease. Commonly we see normochromic normocytic anemia maybe reflect the gastrointestinal hemorrhage or due to a chronicity or chronic disease of the liver, or maybe cause hypochromic microcytic anemia due to iron deficiency or due to chronic blood loss lead to microcytic hypochromic, or maybe see macrocytosis, increase MCV. This occur in patient alcoholic, or increased target cell in the jaundice patient, also present of macrocytosis. So macrocytosis present in the jaundice patient, present alcoholic. Microcytic hypochromic indicated iron deficiency anemia from the chronic blood loss, but commonly normochromic normocytic anemia indicate the chronic anemia of a chronic disease. Leukopenia may present in the portal hypertension occur due to hypersiblynism. So the hypersiblynism commonly in the patient with liver disease, for example, liver cirrhosis, lead to decrease engulfing of the white BC, engulfing of the platelet and RBC, lead to pancytopenia, leukopenia, and thrombocytopenia and anemia. But when the increased white BC commonly occur in cholangitis, alcoholic hepatitis, and hepatic abscess, increased white BC in this disease. Atypical lymphocyte occur in the infectious mononucleosis, maybe cause hepatitis. The thrombocytopenia, other abnormality in the blood, is common in the cirrhosis due to hypersiblynism. Okay? Or increased breakdown because of hypersiblynism. But increased platelet is unusual in the patient with liver disease, but maybe occur in the active gastrointestinal hemorrhage, or rarely due to hepatocellular carcinoma. The measurement of liver damage, or severity of liver damage, how to assess the severity? Is this disease of the liver mild, moderate, or severe? Can be assessed by the 3 tests. Firstly, serum albumin. This marker of the synthetic function, and it is valuable guide to the severity or and the chronicity of liver disease. So decrease in the bilirubin in the liver disease is a bad prognosis sign. In acute liver disease, the serum bilirubin normal, but when there is a chronic disease, lead to hypoalbuminemia. So the albumin give me idea about the severity of liver disease and the chronicity of liver disease. When the serum albumin decrease, that means chronic liver disease. When serum albumin decrease, that means more severe liver disease. Another indicator for severity or prothrombin time. This also a marker of synthetic function. Because of its short half-life, it is sensitive indicator for both acute and chronic liver disease. عكس serum albumin because long half-life, about 1 month. So albumin indicate the chronicity. But prothrombin time, when there is a severe acute destruction of the hepatocyte, lead to prolong of BT that indicate that bad prognosis. But should be ensured that not due to vitamin K deficit. How to differentiate that? We injected a 10 milligram of vitamin K IV, and then after 5 minutes or 15 minutes, we assay the BT. If the corrected BT after injection of vitamin K, that means due to vitamin K deficit. But if not corrected BT after injection of vitamin K, that means due to disease of the liver. If that means there is a destruction of the hepatocyte, lead to decreased synthesis of the coagulating factor and a prolongation of BT. Another indication for the severity of the liver damage called bilirubin. So the degree of hyperbilirubinemia go with both. So the degree of the elevation of bilirubin also reflects the damage of the liver cells. So there is when increase the serum bilirubin, that mean bad prognosis. Another aim or investigation, the test that detect the structural effect in the liver, اللي هي الimaging technique. The simplest and commonly used investigation technique اللي هو الimaging technique هي ultrasound examination. It's non-invasive, safe, relatively cheap technique. The normal liver and the ultrasound appear to be homogeneous structure. The gallbladder, common bile duct, pancreas, portal vein, and other structure in the abdomen can be visualized. The abdominal ultrasound is useful in the following. We detect if there is any lymph node enlargement of the node, if there is a malignancy of lymph node, if there is infiltrative disease of lymph node in the liver. A jaundice patient detected whether intra or extrabiliary duct dilatation by ultrasound. If there is dilated biliary system, that means the obstructed. If not dilated, that means maybe other cause. If there is a large liver, enlarged spleen can be detected by ultrasound. The ultrasound detect if there is a gallstone. Focal liver disease more than 1 cm. If less than 1 cm, difficult to detect by ultrasound. We need other tests, CT like MRI. But the nodule more than 1 cm can be detected by ultrasound. General parenchymal liver disease, example fatty liver, can be detected by ultrasound. Assess the portal and hepatic vein patency. It is a good at identified liver abnormality such cyst, tumor, pancreatic mass can be detected by ultrasound, and fluid collection in the abdomen, example ascites. But sometimes this common overlap by the bowel gases. If there is a lot of bowel gases that handle of this test. Other structural test used to detect any structural abnormality, CT scan, اللي هو computed tomography examination. This technique is complementary, مكمل to ultrasound, which should be usually be performed first. It is provide excellent visualization of the liver pancreas, spleen, lymph node, and lesion of the porta hepatis. CT scan allow the assessment of the size, shape, and density of liver disease and can be characterized of focal lesion if even less than 1 cm that not detected by the ultrasound. Magnetic resonance imaging MRI. MRI provide a cross-sectional image in any plane within the body. MRI probably the most sensitive investigation of the focal liver disease. A contrast agent with injection of gadolinium allow further categorization of the lesion, especially if the patient is sensitive to the iodine contrast. So the patient needs the contrast, but is sensitive to iodine, we can do the MRI with contrast. Magnetic resonance cholangiography اللي هو المختصر MRCP اللي هي Magnetic Resonance Cholangiopancreatography. This technique involved the manipulation of the volume of data acquired by the MRI. A heavy T2-weighted sequence enhanced the visualization of the water-filled bile duct and pancreatic duct to provide a high-quality image of the ductal anatomy. This non-specific technique is replace the diagnostic test اللي called ERCP. هنا هو non-invasive can be give the idea about the biliary system. راح ينطينا صورة للbiliary system without OGD, without engaging. But the difficulty هنا difficult to only diagnostic, not therapeutic. What the value of the X-ray in the liver disease? The plain X-ray have a limited role in the investigation of hepatobiliary disease. A chest X-ray may show a small amount of the subphrenic gases, abnormality of diaphragmatic contour, and relatively pulmonary nodules, or include the secondaries. There are rarely regarded, but can be shown gallstone. Some gallstone can be seen by the X-ray. About 10% of the gallstone contain enough calcium to be seen by X-ray. Air in the biliary tree. The X-ray ممكن نشوف if there's air in the biliary tree. This indicate if recent instrumentation or recent surgery, or there is fistula between the intestine and the gallbladder. Also, pancreatic calcification can be detected by X-ray, or rarely calcification in the gallbladder called porcelain gallbladder. This very rare disease can be detected. So the X-ray, plain X-ray are rarely used in the Ivatobuliary disease. Other tests called cholecystogram. The cholecystogram is rarely used now, but the cholecystogram is an X-ray procedure used to help evaluation of gallbladder, where specific diet is consumed prior to the test. And contrast tablet also swallowed to help visualization by X-ray. There's tablet with contrast can be taken by mouth, and then with a few minutes taken X-ray to visualize of the biliary and gallbladder. This test is used to help the diagnosis, the disorder of the liver and gallbladder. Include gallstone or tumor. This test is rarely used, but used in specific situation when the evaluation of the gallbladder function. So, give the idea about the gallbladder during relaxation and during the contraction of the gallbladder, so give idea of the contractility and function of gallbladder. That's rarely used to because replaced by other new investigation. Other rarely used test called radionucleotide imaging, scintigraphy or scintigraphy, a technetium-99 colloid scan. This colloid is injected IV to be taken by the reticuloendothelial cell of the liver and spleen. So detect any filling defect, indicate if there is a tumor or cyst or abscess in the liver. So this material taken by normal hepatocyte, but not taken by cyst or tumor or abscess, lead to filling defect. This filling defect can give the idea about the underlying disease. But in the chronic liver disease, poorly used or not used because the ability to taken by the hepatocytes are poor. Also, it is rarely used because replaced by new test, example, ultrasound. The commonly test used in our clinic اللي هو endoscopy. Upper GIT endoscopy is used for the diagnosis, treatment of varices, for diagnosis and treatment of varices, detection of the sign of portal hypertension, or detection of the hypertensive gastropathy, if there is any lesion, tumor in the stomach, in the esophagus, peptic ulcer disease, all these can be detected by the endoscope. Endoscopic ultrasound, EUS, this technique, a small high-frequency ultrasound probe, is mounted in the tip of the endoscope and placed by the direct vision into the duodenum. This close proximity of the probe to pancreas, biliary tree, provide high resolution of ultrasound image. هنا بهذا الاندوسكوب at the end of the scope بتخلي كاميرا that lead to visualize the او كاميرا او ultrasound that can be visualized is nearby lesion قريبه من الستومك قريبه from OGD, example the pancreas, nearby biliary system can be detected. This EUS, it's allow the accurate staging of a small and potential operable pancreatic tumor. So if there is a small pancreatic tumor cannot detected by ultrasound, CT scan, MRI, can be used EUS to detect of this tumor. Also, over a less invasive method for bile duct imaging. Third, it has highly accuracy in detection of neuroendocrine tumor of the pancreas. رابعة, US guide for fine needle aspiration of tumor provided by this test. هو نقدر نسوي aspiration from this small tumor and send it for histopathology detection of any small tumor in the pancreas or nearby structure. Also visualization of the any bile duct imaging. Percutaneous transhepatic cholangiography, اللي هي BTC, is rarely used. That under local anesthesia through the skin, file flexible needle that pass into the liver and lead to contrast injected to the liver, lead to colonization of the biliary system and visualization of biliary system. Now, this technique is also rarely used because high risk of bleeding, risk of cholangitis and septicemia, so not used. احنا نذكره هنا بهاي المحاضرة بس هو rarely used. Endoscopic retrograde cholangioperiotography, ERCP. ERCP يختلف عن MRCP. ERCP also diagnostic and therapeutic. نستفاد من عنده for diagnosis of biliary disease, also diagnostic. This technique is used to outline the biliary and pancreatic duct. It's involved the passage of the endoscope into the second part of the duodenum and colonization of the ampulla of Fata, and then contrast injected into the biliary system, and the patient is screened radiologically. It is a diagnostic and therapeutic of procedure can be carried out, like biliary stone removal. If there is small stone in the ampulla of water can be removed by this, by endoscope. Or CB, stenting, common bile duct stenting. خلي stent, if there is stenosis of common bile duct, can be put a stent in by this test. Or taking biopsy from tumor of ampulla of water can be taken biopsy through ERC. Fourth, the test or investigation identify the specific cause. If you suspected, if there is a specific liver disease, there is a specific test for this disease. For example, a chronic hepatitis B. If there is suspicion of hepatitis B, we see for hepatitis B surface antigen or other marker, hepatitis E antigen, hepatitis E antibody, to evaluation of the hepatobiliary disease. Another, if there is suspicion of a chronic hepatitis C, we see the blood for hepatitis C antibody. Or as say there are an A gene. If suspected primary biliary cirrhosis, we see for antimitochondrial antibody or liver biopsy. Primary sclerosing cholangitis, seen for MRCB or ANCA. ANCA anti-nucleic cytoplasmic antibody. Autoimmune hepatitis, seen for specific antibody اللي هي anti-microsomal أو liver kidney antibody أو liver biopsy أو increased immunoglobulin. Hemochromatosis suspicion, seen for transferrin saturation or ferritin assay or gene test. Wilson disease, seen for ceruloplasmin assay or 24-hour cover collection or urine and cover assay. Suspicion of antitrypsin, we see for antitrypsin level or antitrypsin gene assay. A drug-induced hepatitis, we see for liver function test or liver biopsy. Suspicion of celiac disease associated with liver disease and this specific TTG or endomysomal antibody or antiglidine antibody assay or OGD to take in biopsy. Other investigation if to assay the complication of liver disease. There is a specific, when the end stage of liver cirrhosis are complicated by the following complication, example, hepatic encephalopathy. The hepatic encephalopathy are common complication of the liver cirrhosis. How to confirm diagnosis? By the following test. Cytochromic test, or special tests to assay the mentality of the patient, or electroencephalograph, EEG, or sensory abort potential. This test to confirm the encephalopathy. If the liver cirrhosis complicated by portal hypertension, how to confirm diagnosis of portal hypertension? By upper endoscopy to see if there is varices. If there is liver varices, esophageal varices, lower esophageal varices, indicate there is portal hypertension. Ovarium swallow and meal, also liver ultrasound or liver Doppler ultrasound, abdominal CT scan, weighted hepatic venous pressure measurement, venography of the hepatic vein also can be used in the portal hypertension. If complication ascites, acetic fluid analysis and sampling analysis, liver ultrasound or abdominal ultrasound to detect if there is a fluid, or rarely a laparoscopy. Renal failure complicated of liver disease by urine analysis or renal ultrasound, central venous pressure recording or renal biopsy. Or we suspected the complication of the hepatocellular carcinoma are commonly complication of liver cirrhosis. We see for alpha fetoprotein, the alpha fetoprotein increase in the hepatocellular carcinoma. Or by ultrasound, detect if there is a mass in the liver. Abdominal CT also can be visualized if there is hepatocellular carcinoma, hepatic angiography or laparoscopy of rare use. investigation of the complication of the hepatic cirrhosis. Other, so from all the lecture, all the talk above can be summarized by this diagram. This diagram, how to approach to the patient with hepatobiliary disease. This common question to the student, how to approach the hepatobiliary disease, how to approach to the jaundice patient, how to approach to the patient who suspected of the liver disease. So from the good history of the patient and clinical examination, then the first step, send the patient to the first line investigation اللي هو liver function test. The liver function tests are very important in the approach to the patient with liver disease. If the liver function test normal, that means there is no liver disease. Okay, that means the other liver injury. So if the normal, that means hemolysis or conjugated hyperbilirubinemia. So if the patient jaundice but liver function is normal, that indicates the hematological disease, not liver disease. Example, sickle cell anemia, thalassemia, or hemolytic anemia that lead to increased bilirubin, but not due to the liver disease. But when liver function tests increase, اللي هي AST or ALT or electrophoresis increase, that there is abnormality in the liver. So we send the patient to the ultrasound. The ultrasound can be differentiated either obstructive or not obstructive. If the by ultrasound there is a dilated of the biliary duct, that means obstructive jaundice or obstructive liver disease. So evaluation by the obstruction seen for ERCP, MRCP, BTC, or CT scan. This test very important to diagnosis of the biliary. But when ultrasound, there is no dilatation of duct. That means there is no obstructive disease. So send the patient, the jaundice patient, to the evaluation of any parenchymal liver disease. Example, GGT, viral marker, autoimmune marker, KF ring for liver, for Wilson disease, or liver biopsy إلى آخره. So from this diagram can be reached to the final diagnosis. This picture show the test called percutaneous transhepatic cholangiography. نشوف هنا the white tissue, it is a biliary system injected through the probe from the skin to the liver. This picture shows the CT scan of the liver with multiple secondaries in the liver. This picture shows ARCP, اللي هي Endoscopic Retrograde Cholangiobacteriatography. This shows the OGD injected the dye inside the biliary system through the ampulla of butter, and then show there is a large tumor or fistula between the biliary system and gallbladder. Thank you and good luck.